one is actually an interesting thing in that this talk that you're going to hear now is actually recorded right at the very, very, very start of the COVID response. So this is when the speaker, Shannon Nott, who's one of our young doctors, who's taken on a management role in rural, was thinking through how he was going to respond to the COVID situation and to do the appropriate response for his patients in Western New South Wales, which is the state around Sydney. Many of you know Sydney in Australia. So I'll just go to the video, and then we'll come back and hopefully have some really good discussion around what's transpired since then, but also what people's experience has been. So.
Hi, I'm Shannon Nott. I'm the Rural Director of Medical Services for Western New South Wales Local Health District. And today I'm going to provide you with an overview of how we're utilising our existing virtual health services to respond to COVID-19, as well as provide you with a sense of how we're utilising virtual healthcare to be able to provide care to many rural and remote communities that would otherwise struggle for a health workforce. Before I begin, I'd like to acknowledge that today I'm filming this from Aboriginal land, specifically Wiradjuri land. I'd like to pay my respects to elders past, present and future, and like to also acknowledge all of those First Nations people across the globe that may be watching this video today. I hope that through the work that each of us are doing in our respective parts of the globe, we continue to work alongside First Nations people to be able to address the inequalities that exist in regards to healthcare outcomes. So to give you some context, I am the Rural Director of Medical Services for a region called Western New South Wales. That region spans about 280,000 square kilometres. It encompasses 37 hospitals, 60 community health centres. Much of our region is quite rural, and in some of those parts of our region are considered quite remote. We have quite significant health disparities compared to our metropolitan colleagues across our region. We also have the tyranny of distance for us, with our staff travelling around 13 million kilometres every year to be able to treat patients. To put that into perspective, that 13 million breaks down to be almost a lap of the globe every day for our staff. This doesn't include the amount of kilometres that our patients have to travel every day to be able to access healthcare. And some conservative figures have shown that that number can be 3 to 5-fold of what our staff are travelling every year. For us, we have some significant challenges, like many parts of the globe, in regards to rural and remote healthcare. Those challenges include quite clearly around the workforce disparities. We struggle to get many doctors and nurses into our rural and remote communities, and have had to adapt to be able to provide ongoing care, and particularly ongoing hospital-based care for our communities. So this sparked many years ago a bit of a journey for us to be able to look into where were we at in regards to how we can support our clinicians on the ground. Clearly our mandate as a district is to support the hospital services, but we recognise that in many of these small rural and remote communities that we must also be able to support our primary care workforce. We underwent, I suppose, a telehealth strategy back in 2015 when we did a bit of a stock take in regards to our readiness for change and what we needed to do back then to be able to support our communities with a robust and contemporary telehealth service that spanned multiple areas and multiple subsets of clinical models of care. That review really was an eye-opener for us. We recognised some key challenges around some basics around network capacity, around broadband and bandwidth issues, around our business in terms of how are we supporting our clinicians and driving innovation and supporting our workflows in regards to the virtual space. We're also keen to understand how we can support and enable our workforce more into the future to be able to support them in establishing new programs as well as improving the programs that we have already in place across the region. I myself have been very fortunate to have undertaken a range of research visits to a number of places across the globe who have been utilising telehealth programs in one way or another to be able to address this issue of distance and the issue of workforce inequity and also health outcome inequality that exists between metropolitan regions, rural and those rural and remote regions of the globe. These, I suppose, organisations, are a number of them, and they're not all of them, that have been able to learn from and seek guidance from as we've gone down this telehealth journey. And certainly we've been able to utilise many of the lessons learned from these organisations as we've developed our own telehealth systems moving forward. Really, this has led to us being able to establish a comprehensive virtual health service today. So in less than 5 years, we've gone from very few models of care that have been enabled via telehealth to over 70 models of care, 60,000 care events every year across a wide range of fields. We're looking at increasing those, and certainly within the COVID context, those care events have grown significantly, particularly as we face challenges of social distancing, face the challenges of ensuring that we can treat and manage our patients outside of normal hospital environments, and also how do we bolster our workforce capacity across some of our very vulnerable rural and remote communities. So as you can see there's a range of models of care, from emergency and critical care support through to mental health, our rural generalists, which I will talk about a little bit today, specialty consults, a virtual allied health service where we can support communities which have a lack of access to allied health support, and a range of other services, working with our cancer patients as well around how can we ensure that they can get access to chemotherapy closer to home, how do we support our dialysis patients who may live in remote regions around troubleshooting their hemodialysis. And particularly in this environment is how do we support our aged care facilities moving forward, particularly as our residents in many of our aged care facilities are distanced from their loved ones, and also how do we ensure we protect them from, I suppose, exposing them to risk of contracting COVID-19. So I'm going to talk about three main areas out of that. One of those is V-Care, which is essentially, if you could think of it as an emergency and acute care support hub for our 35 rural and remote communities. V-Care has run through various forms since 2006 in our region, where we originally created the roof-mounted handheld zoom cameras in Australia. We were the first region to utilise this system to be able to, at that stage, provide intensive care support into the most remote of communities. These days we've become a lot more sophisticated, using EMR systems, EHR systems, a range of cameras to be able to support our rural and remote clinicians to provide specialist level advice and support to our rural and remote areas. This service has been able to be supported most recently by our virtual rural generalist service. And this service particularly has been one that's been really able to keep the doors open for many of our rural and remote facilities. This service provides rural generalist expert support into those communities that don't have access to a local doctor, or where local doctors have requested that they get fatigue management support, after hours support, weekend support, or even leave support in their community, so that they know that the care of their patients can continue by doctors who are experts in providing care in rural and remote environments. So we utilise telehealth infrastructure to be able to work alongside nurses who are quite skilled in emergency care, in acute care services, and are working alongside those nurses to be able to also upskill them in areas that they may have traditionally not needed to do because that role would have been filled by doctors. So we're working alongside those nursing staff and those skilled nursing staff to be able to provide rural generalists medical support into communities. That includes being able to do ad hoc emergency reviews and patient reviews as required across emergency departments, inpatient facilities, residential aged care. We're also doing ward rounds, so utilising what we call wallies or wireless trolleys, which you can see there in the picture, to be able to bring care to the patient's bedside so that we can include the patient in their care, to be able to include their loved ones in their care, and to ensure that we're utilising what would be normally contemporary medical standards in a hospital in terms of ward rounds and bringing that into the virtual space. So allowing our expert rural generalists to be able to provide care into hospitals so that we can continue to have patients admitted into facilities that allow them to be as close to home as possible. In regards to the virtual rural generalist service, just for some basic numbers, that service has grown quite significantly. We transitioned that service from a primarily phone-based service that existed for about 10 years across our region to a fully virtual service at the end of January. And lucky for us, that timing couldn't have been more pertinent given the worldwide pandemic that is COVID-19. Since then, each day we have seen our virtual generalist service see 60 to 100 or over 100 patients every day in regards to being able to ensure that they're treated closer to home, that they're closer to loved ones, and that we utilise the infrastructure that has been provided in many of our rural and remote small communities. That over a 24-hour period, those 60 to 100 consults, over 7 hours of that time is spent on camera each day. Many, many more hours are spent on the phone directly to our nurses, directly to patients as well. This service supports up to 35 communities across our region. And essentially, it also provides us a significant support for not only our nursing staff, but our GPs working in these communities where they may feel that they need support and help, particularly in those communities that have only a single doctor or a handful of doctors. The benefits of VCare and VRGS, or the Virtual Rural Generalist Service, combined is that together they are enablers to I suppose, to allow us to be able to treat patients as close to home as possible, reducing travel time for our patients, optimising the use of our local resources. We're also keen with these services to look at how we can improve our population access to not only specialist advice, but our rural generalist advice, which we deem as specialists in rural and remote care across our region. We also look to how we can utilise a virtual care hub of sorts to be able to provide clinical support for our communities, as I mentioned before, addressing some issues around unwarranted clinical variation, and hopefully assisting with continual improvement around quality and safety KPIs or areas for us to improve moving forward. We also have recognised that it's built some capacity for our rural clinicians. It has reinforced that our clinicians on the ground are an absolute vital resource for us. And if we can support them virtually or through virtual models to enable them to have safe working practices and to enable some longevity in their careers, particularly in some of those remote regions, then that's an added benefit as well. We also see that through these services, we can establish some really strong relationships between clinicians across facilities, across emergency departments in our region. That is not only around being able to provide the care virtually, but certainly there's an impetus and an importance for doctors in these services to be able to get out on the ground. The virtual rural generalist service doctors will spend at least a quarter of their shifts each year on the ground in community, building relationships with not only their patients but also nursing staff and getting an understanding of what it's like living and working in some of these communities which they serve via virtual models of care. And then finally for us as well, it's about how can we utilise these models to increase the continuity of care for patients and their families. And that's particularly so by treating those patients as close to home and as close to their community supports. We've also utilised recently and worked in partnership with Philips around how can we utilise the data that we capture on a day-to-day basis. So in terms of patient observations, patient vitals and pathology, how do we utilise that to be able to detect deterioration? We've worked with Philips around utilising their eCare Manager solution to be able to provide 24/7 monitoring of vital signs for emergency departments and patients in inpatient units in our rural and remote sites. And really this is to provide an additional safety net for our patients across these regions, particularly in areas where we may have workforce vulnerabilities. This data is utilised to be able to create early warning scores and systems to be able to detect deterioration early and be able to escalate either locally through local doctors or through either the VCare or VRGS services to be able to ensure that we're providing the best care we can for our patients on the ground. So where actually do all of these models that have been existing prior to COVID fit in for us? Well, really what we're learning is that these systems are scalable and provide us with flexibility across our region to be able to build this system capacity to be able to treat people close to home. And that also extends into the home environment. For us to ensure that we have appropriate surge capacity across our region, we have built into that surge plans or pandemic plans the capacity to expand these services to be able to provide virtual monitoring into the home if needed, particularly should we have some outbreaks of COVID where we're managing people in community close to home so that they're outside of a hospital environment to protect vulnerable patients in our hospitals, as well as ensuring that we have quite safe and high quality services in regards to follow-up for these patients in the community. We also are utilising these services going forward to promote shared decision-making for COVID-19, recognising that there are very few experts in this novel disease. So we are promoting very much this shared decision-making, which is not always an option for rural and remote environments where you may be a sole practitioner or one of a few practitioners in rural and remote. So being able to utilise our services where people can phone a friend, get additional support, and for us to also ensure that our virtual staff have the most recent evidence in regards to best practice in managing and also testing for COVID-19. We're also looking to utilise these services alongside our existing services on the ground to provide optimal health outcomes for our rural hospitals, particularly with that added safety net in regards to the remote monitoring. We're also utilising our virtual health pathways and processes to be able to educate our rural health staff around keeping up to date on COVID-19 guidelines. So lessons learned. For us to be able to do this, we've had to have really robust governance systems. We've had to really refine our models of care. We've had to really utilise and look at how can we provide appropriate IT infrastructure and support. And for us moving forward, as we look to try and improve services, how do we utilise our data, metrics and analytics to be able to continually improve our services and ensure that patients are kept safe as we look to expand and support virtual health across our communities. Thank you very much for listening to this talk today. I hope you found it useful. I've included my email address below should you have any questions. And certainly we'll be more than happy to provide further advice around some of our programs moving forward. Thank you.
Well, thanks, Shannon, and hopefully, yes, we've got Shannon online. Shannon sent me a text message in the middle of all that saying that there was a storm coming over his satellite dish and he might not be able to join us. So it looks like hopefully the storm's not with us at the moment. If I could just summarise, Shannon, and then I'm going to ask you to give a bit of an update on what's actually happened over the last few months. And then we'll have some questions from the audience. I think we'll just have verbal questions and I'll monitor the chat. But it seems that what you've been doing here is supporting the residents, the resident health professionals, both with some after hours care, being another virtual health professional in the community, and also helping their educational growth by providing that. You've also been providing more services for rural patients and less transfers, and you've been providing some e-monitoring. The balance always that's tough with this is trying to make sure that it actually does complement all of those things and doesn't just act as a reason for governments to say, well, we're going to close these places because we can do it all without a doctor there. So it's, I think, an interesting story till then. And I'd like to, if you could actually help now to talk a bit more to us about what's happened since then. And then we'll open to questions and I'll get in and monitor the chat while you're doing that. Finally, at the end of the session, on a little bit later in the session, I'd like to hear other people's experiences, and certainly if you want to chip those in to chat to Shannon as we're going along. So first, over to you, Shannon, just for a bit of an update.
Thanks, Bruce, and hopefully my audio comes across well. If it doesn't, please let me know, and I'll probably switch off my video because I am on satellite broadband at the moment. So just pull us up. The talk that was just shared with everyone was in May, and since then, in at least our state and most places across Australia, each of the states were essentially sectioned off from one another in the pandemic. And for us in Western New South Wales, we're highly reliant on quite a number of fly-in, fly-out doctors that were essentially pretty much permanent doctors into some of our most remote communities. Many of those came from other states, and when our borders were closed, we actually lost a significant proportion of our workforce, and the local locum workforce in New South Wales wasn't able to support many of our communities. And so we had to utilise our nurses on the ground, the doctors that we did have on the ground and the doctors that we did have in the state to be able to support many of our towns. But that within itself, while Australia didn't have the numbers of COVID patients that some other countries across the world did, certainly the impact for some of our rural and remote communities was just as intense, particularly from a workforce perspective, particularly for us in Western New South Wales. So we had to utilise our virtual services to support quite a number of towns across our region. And I think Bruce's points around getting the balance right is a really, really important question. It is a really important thing for us to make sure that we continue to invest in local regions into rural generalists, not just from a medical perspective, but also rural generalists from nursing and allied health perspectives as well, and ensuring that we've got robust healthcare teams that are able to support one another. For me, in terms of reflecting on the work that we've been doing, and certainly this year, that part of that healthcare team certainly is, or at least in our region, a virtual healthcare team. How can they support, and I want to stress that term, support our workforce on the ground? How do we bring in specialised services, not necessarily specialists, but specialised services? So even rural generalists with advanced skills in areas like palliative care and paediatrics and mental health, how do we bring them into communities where we might not have access to them at the front line? How do we also bring in those specialist services in terms of bringing in specialists that would not otherwise be on the ground or not on the ground as often as they would, so that we can have really high performing healthcare teams in communities, and where we can support particularly new rural generalists or younger rural generalists coming into our region. When we speak with quite a number of interns, residents, and even medical students, a lot of people are really excited about the prospect of joining rural journalism. One of the things that scares people is the feeling of the buck stopping completely with them. And then the other thing that we find that puts off younger doctors potentially coming to our region is the concept of having to be 24/7 on call and being it in some of the communities, and certainly during this year's have requested that our virtual teams, particularly after hours, to support them and to ensure that they can be kept fresh, to help support in regards to fatigue management as well. And also, I suppose, since I recorded this presentation, the state of New South Wales across both urban and metropolitan, urban and rural and remote regions, realised that as a whole, as a system, rural and remote parts of our state were much further advanced in regards to being able to uplift and scale virtual programs as the globe moved to telehealth more, and that as a state, though, we were relatively immature in regards to being able to transition. There were pockets, and mostly led by rural regions, to transition across into telehealth when it was needed. But as a state, we weren't. So that our state invested in virtual care acceleration and virtual care accelerator as an entity to be able to help clinicians on the ground design models of care, transition across into virtual programs, and also looked at how they could have a coalition or a community of practice of clinicians who are experts in virtual care to be able to directly advise New South Wales Health to address any issues that arose during the COVID pandemic. And so those type of initiatives actually helped us mature and continue to mature as a health system moving forward.
Thanks, Shannon. We've got a few questions coming in. Actually, we've got a bit of a patient experience from Richard Fitton, just talking about the benefits of some of this. Richard, did you want to reflect on that and maybe make a comment or have a question of Shannon?
Thank you very much for inviting my comments. I'm a friend of John Wynne Jones, who's introduced me to your organisation. I've been working for nearly 30 years to give patients copies of their own records and to give them their own blood pressure machines and to encourage them to manage their own health care. I'm working currently with the General Medical Council of the United Kingdom, who've recently, on the 9th of November, published a new set of standards for doctors to share contemporary records with patients. Well, they haven't. It's on decision making and consent, and basically, the document is supporting the fact that patients should have access to all information that's recorded about them. We have had a number of patients who have very much enjoyed being able to have access to all of their information. We did a small study on 60 patients who were regularly accessing their records, and it was only a small study, but it showed that we could increase capacity in general practice perhaps by 15%, because patients didn't need to ring up the doctor or see the nurse or see the doctor to get their own results, particularly patients who'd had a long-term condition for 20 or 30 years. The need to, so I think that's it. We have been in contact with Dr. Neelam Dhingra at the WHO patient safety strategy, and she's supportive of this. And indeed, the recent WHO digital strategy is also supportive of patient access in their own records. It's a fairly obvious concept that people actually like to get the weather report the same day, and they like to get the news the same day. And it just seems to me very strange that they spend 4 or 5 hours a day on their laptops and computers and radios and televisions listening to information, but they don't actually have the chance to get up-to-date information about themselves. So a group of us in England have sort of waged a fairly successful campaign negotiating with indemnity societies, the government, the British Medical Association. We've been to UNESCO to meet a rapporteur from the 1990s UNESCO working group on the use of human genetic data to look at the ethical issues of people actually having access to all of their information immediately, even in my mind before the doctor sees them, especially if the doctor's on holiday for 2 weeks. So I don't know if that's helpful. We have a lot of information. We've written guidance. We had a program led by the General Medical Council of this country nearly 13 years ago to actually engage with patients and professional bodies to write guidance for sharing data, particularly in respect to data about third parties, data given by third parties, children, and data harm. Although in fact, looking at the General Medical Council guidance on decision-making consent, I think the General Medical Council, which is a pretty sound body, thinks that patients should be able to see almost everything in the notes. It's very rare for people not to be able to see anything. I'm sorry, that's quite a long spiel, but it's a pleasure to be able to share that story. We have actually got another 4 or 5 stories, and I'll take the liberty of sending them to you. These are real people, and I have got their consent to share their information. So I'll share those with you during your event. Thank you very much.
Thanks, Richard. And I think you make a really interesting point about virtual care being also that the other way too, is that patients can actually see what's happening. I might go to a couple more questions and then get a comment back from Shannon about them. So if we could stack a couple up here. Ewan was talking, and there's a bit of other chatter around the utility and the cost of different home monitoring programs. They can be, as has been recognised, some very simple things or quite more complex monitoring. Ewan, did you want to say anything more about that and the difficulties of that?
Thanks, Bruce. Look, I just hope you can hear me. I really wanted to say thank you to Shannon for the innovation that he's exercised in pulling things together in his area. I know that my state had tried several trials of the Philips system, but it seemed to be very capital intensive. Have you seen a significant return on the investment? Does it pay for itself, or is it still something that requires a lot of investment? Was my thinking about that, because I'm really excited by what you've done, and I'd like to see it reproduced everywhere in Australia, really. Just interested in how that monitoring works and what you're seeing as outcomes that could make the case for it more broadly.
Shannon, would you like
Thanks.
to address maybe both of those issues, the one about patient notes and the monitoring? Thanks.
Yeah, sure. Thanks, Bruce. I'll start with the patient notes side of things and then move across into the remote monitoring aspects. I think it's a no-brainer sharing data and information with patients. I think these days, as information is becoming more and more readily available at our fingertips, the concept of self-management of chronic disease or being as well as people can in community means that we need to empower them with information. And certainly in Australia, there's been a big push around My Health Record, which aims to bring together both primary care data and hospital data so that patients can access that through a portal. And certainly when the Australian Digital Health Agency, which runs that, was looking at, I suppose, the case for change, it was quite large. It was overwhelmingly positive that patients wanted more access to their health data. So I think that makes perfect sense. In regards to Ewan's points around remote monitoring, there's a couple aspects to that that I think have different use cases or I suppose return on investment depending on who's funding it. One, which is what we've focused on because we're a state-run organisation. For those people from overseas not familiar with the Australian funding system, state-run health organisations primarily are responsible for hospitals, whereas federal funding goes into primary care. So as a state-run health organisation, we focus predominantly on in-hospital monitoring. And the business case, Ewan, for that was looking at the numbers of adverse events that we had, particularly around the recognition of the deteriorating patient. And I think clinical governance systems worldwide recognise this concept of recognition of deterioration as a significant challenge. And obviously health-acquired complications, adverse health events cost the systems significant amounts of money globally, not to mention that it's just not good for us to be able to, I suppose, bury our heads in the sand and say, well, it's good enough for patients to deteriorate in any of our hospitals, regardless of whether it's rural, metropolitan or others. So the business case for us was around this recognition of deteriorating patients, trying to address it, but also making sure that our clinicians, and by clinicians I mean doctors and nurses on the ground, have additional safety nets to be able to support the care that they have. And so for those people that aren't familiar with the Australian context, in most of our very small rural sites, they don't have doctors in the hospital 24/7. They work in the community in general practice, and after hours are at home. So there's no resident doctor or intern doctor in the facility. So largely they're run by nursing staff. And many of those nursing staff, particularly after hours, can be quite busy and might not always pick up on patient deterioration. So for us, the business case and certainly Ewan, in regards to some of the outcomes that we're seeing now, is this addressing significant deterioration in our communities and also providing an additional layer of support for patients and clinicians in some of our most remote or rural sites. The other component of remote monitoring that I'm aware that Queensland and also across Australia has invested in at varying times in terms of pilots, and certainly globally, and I note that there's quite a number of Canadians on the call, or at least a couple of Canadians whose names I'm familiar with. And globally, remote monitoring in the community, particularly remote monitoring of chronic disease, has had a lot of attention, particularly looking at how do we empower patients to self-manage chronic disease in community. There's lots of different models. There's mixed evidence and mixed literature in regards to the benefits. And generally, the literature forms in two camps, at least in my mind. One is where there's a relatively light touch approach where models of care have been reliant on patient taking observations, them getting fed into a system and observations being flagged at certain markers where heart rate's either too high or weight's going off too high or blood pressure low or those type of things. So really sort of stagnant metrics. Without any education or mentoring around it. And generally those type of systems end up showing very little benefit or net benefit for patients. The systems where they integrate intelligence into it, so looking at deterioration over time, delta scores and changes in regards to patient baseline, but also integrate a education, training, and I suppose a wellness model where clinicians that are involved in these programs also look at helping patients self-manage chronic disease, mentor them to or educate them around how they can better manage their chronic diseases. Those programs generally have much better outcomes, and there is consistently across the globe net benefit in regards to reduced hospitalizations, reduced emergency department visits, reduced walk-in clinic visits in terms of ad hoc primary care appointments. And generally in Australia, we had the CSIRO telehome care trials that did show for some of the programs that they ran, there was a return on investment around $6 per every dollar spent on home monitoring software. There are some programs in regards to remote monitoring depending on the licenses, and I think this is where we as clinicians need to be really careful around falling in the trap of utilising home monitoring programs, is that some of them are dependent on a person being in a program or being monitored each year. So essentially there's a cost per person per year for the length that they're on the program. And there are some programs out there or vendors out there that try and hook patients up to this for life. And in my personal opinion, I don't think that that's a good thing. We want to be able to have patients living well in the community, have the toolkit or skills to be able to manage their chronic disease and live well in the community, not being reliant on a nurse or a set of doctors continually monitoring their condition. And then the last thing that I'll add to that is that the programs where I believe that there is best benefit is that there is shared care or integrated care with the patient's primary care provider, and in most cases that's their GP or family physician. So making sure that links there, because quite a number of them, and you and up in your region, up in Westmoreton, most of these up in Queensland, Westmoreton's probably one of the most long-standing programs, and there are faults with that, but that program, I suppose, has connections to primary care providers whilst it is being run by a hospital service.
Thanks, Shannon. And Shannon and Ewan, I'd be very interested to talk to you further, because we're actually trialing the Phillips program here, and I think I'd agree exactly with your points. We've got couple of good points from Joyce and others around two things, and maybe Joyce, you might like to come on and address these. But one's about the strength of telemedicine in actually educating the doctors on site, and not only obviously the resident doctors, but the students and others that are on site, and making sure that they have access to the same sort of education that others will get. And the one that's coming through a fair bit is around the mental health issues at the moment, and the need probably for telehealth to also address the isolation of rural doctors, particularly solo ones. Mind you, my view is that no community should ever only have one doctor. There should be always two, to provide the relief and provide some companionship. But clearly in some places that's all that can happen, or one health professional. Joyce, did you want to make some comments?
Okay, thank you, Bruce. I think my comment was that we actually endeavor to try and get our healthcare professionals holistically trained, so that they're able to work both in the facilities and also in the community. And I keep making reference to our unique program, which makes our institution quite outstanding. That is the Community-Based Education and Service Program. And that one, we train healthcare professionals to work both in the facilities as well as in the communities. So it's quite a comprehensive package. And it starts in the first year of study right up through to the 5th year of study. And it's actually tries to produce a holistic kind of healthcare professional. And as we keep saying, we emphasize that they must have 5 characteristics for which our products are supposed to have. So we train them to make sure they are critical thinkers, analytical, evidence-based, and of course, proactive, and at the same time, agents of change. So I don't know how far other institutions are actually embracing this kind of approach. For us, it's quite unique because it was part of the innovative program. And as we train our these medical psychologists, or the 8 cadres, medical psychologists being one of them, we try to make sure that the teamwork concept is emphasized right from the start. And we try to make sure that in the year 2, they go to the communities, and also in year 5, where they have to address administration and management issues, we also make sure they go as a team. So we don't train our healthcare professionals in their respective silos, but we make sure that they appreciate why they must work as a team right from inception up to when they actually finish their respective programs. And when it comes to addressing mental health issues, we emphasize that these 8 cadres actually understand what they must address when it comes to, regardless of cadre, they must also understand addressing mental health issues for prevention, for promotion, for curative, for rehabilitation, and the final I, which normally stands for intervention, investigation, as well as innovation. So we try to make sure that our healthcare products go out there knowing that they must actually address the scope of work, especially when it also comes to mental health issues. Thank you.
Shannon, your comments?
I just agree with you, Joyce, and I can see Bruce has written a few things in the comments there. We need health professionals in rural and remote communities to work to top of scope. That's our doctors, our nurses, our allied health staff. One thing I would say is, and I'd be interested to hear from the group, I note that there's quite a few educators there, that one thing, certainly in Australia and from observations from afar globally, is that people have realised that telehealth is potentially a part of business as usual for the future. And one thing that we're looking at across our state in New South Wales in Australia is what skill set or what skill deficit do we have in Australia amongst our clinicians to be able to work in a virtual environment. Some of that is understanding fully what can and can't be done by virtual means. How do we educate and make the most out of video conference components? How do we understand, particularly if we get into systems like remote monitoring, whether it be in the hospital system versus in the home, how do we understand the faults of programs that involve algorithms or machine learning, and as we develop programs into the future in terms of artificial intelligence, how do we as doctors or clinicians understand that? And I think that's a real component when we're thinking about virtual care for the future, is what skill sets don't we have currently as clinicians to be able to work to top of scope for this. And I suppose one of the things for the educators and many people teaching medical students and that sort of things is the question that I would have for the group is this being done well anywhere? Because I think there's quite a few pockets globally that are starting to do it, but overall it's probably something that has crept up on clinicians to a degree.
Still a bit of a work in progress, isn't it? We might go to some comments there in a moment. Let's maybe, I notice, Osden, you've been making a few comments about mental health and also the efficacy of telemedicine. I know in Australia we've certainly not had the pressure that there's been on the front line to fully go to telehealth as it might be in other areas. Austin or others, have you got any comments about the good, the bad, and the ugly experiences with it, where it's really what's required at the moment because there's no other choice with it? You there, Austin? Anyone else got any comments about the front line where COVID is really hitting at the moment?
Yeah, Bruce, so I'd like to share, please.
Yeah, Nandita? Yeah.
So essentially just wanted to mention that in the initial days, although telemedicine is being at the moment used for management of patients, we were able to use it to allay the apprehension of healthcare workers. And very, very simply so, the first case that we had in our hospital who turned COVID positive, got him online, and he actually spoke about his experiences, what he felt, what were his apprehensions, how he contracted the disease, what were his symptoms. We made him talk everything about it. And the feedback I got on this session was that, thank you so much. We were so apprehensive about the disease and the effects that it has, or the concerns that exist. And we are feeling so much better now. So I guess that worked well for us, yes.
Can you tell us a bit about his experience and what was the reassuring part? What was the thing that really helped that way?
All right. So he contracted COVID from his mother. Mother had tested positive. At that time, I actually am located in Madhya Pradesh in India. And at that time, Indore, where he stays, had the height of cases. Hospitals at that time were turning down patients because their beds were full. And his mother, even though she tested positive, was told that since you're asymptomatic, head home and be at home. So I actually made him go over the entire process of what were the isolation protocols that he followed. And he's basically a paramedical staff working in the hospital, a washerman actually. And just made him go over the entire, what were the worries, how difficult was it for you to actually take your mother to the hospital, Was she seen? What were the investigations done? What were her symptoms? Did the symptoms aggravate? How sick is she? How many days is it post testing positive? How bad has it been for her? And all throughout, he mentioned that no, we were fine. There was no problem. There were no symptoms. I have also tested positive, but I'm also fine. I have no symptoms. I've just had a bit of a fever and a sore throat, no headache, no diarrhea, no anosmia, no dysgeusia. And I mean, and for a batch of healthcare workers that I had handling a hospital, it actually worked wonders because we had a team going on to the into the COVID hostel, as we call it, looking after COVID patients, and they were extremely petrified about what would happen to them. Although we were sending them in with PPE, but this particular experience of using telemedicine or telehealth services available with us to discuss the situation with this one healthcare worker who was washing, who was associated with washing the linen of that hostel, actually worked wonders for the healthcare staff. That's all I can say. Thanks.
Thanks, Shannon. You just chimed in a bit there. Do you want to say something about that?
Just to agree, I suppose, with Nandita that we've had similar cases across the state where doctors or clinicians in the early phases of the pandemic would have fit and still fits the vulnerable population groups, and there was quite a fair bit of panic in the early phases of the pandemic, both from clinicians really concerned about contracting COVID, but also clinicians concerned about knowing the guidelines and best evidence, which was changing daily or hourly in those early phases of the pandemic. And certainly we had quite a few rural clinicians that were relatively professionally isolated in some of our communities, concerned about whether they would be up to date. And so we utilised our virtual services as support for them. It didn't mean to say that they all needed it, but it was certainly there for a number of our clinicians. And I know from stories across Australia that quite a number of general practices that were concerned about their capability around PPE and that side of things transitioned to teleconsults, and quite a number of them still continue with teleconsults. And one of the big enablers for us in Australia was the government being able to offer that publicly funded through our Medicare services. But I think one of the big opportunities for us all to I suppose learn from COVID is what actually worked well, and so what should we continue, but also what didn't work well. And there was a lot that didn't work well. There are a lot of stories where people moved rapidly to doing teleconsultation either over the phone or video. They weren't set up, they didn't appropriately consult or didn't have the appropriate administrative staff. And that caused a lot of frustration for both clinicians and patients. And I think one of the big things as we get into whatever becomes new business as usual is really learning from the COVID pandemic in terms of what really worked well, what do we need to shift to in terms of how do we, as healthcare systems globally, learn from changes to healthcare during this global pandemic, but also learn from our mistakes and be able to really measure particularly safety and quality metrics. There's a lot of interest in Australia around telehealth now. There always has been, but certainly that has been expedited by a long way during COVID. But we really need to understand, was there an unintended harm, and address that moving forward so that we don't continue to make mistakes as we move forward.
Thanks very much, Shannon. We've got, I notice, Tapesh, it's great to see you again, Tapesh, and you're, as a young doctor and a young doctor in India, your experience is really important. Can you, you'd like to ask a question or make a comment?
Yeah. Hello, everyone. It's really nice to see all of you again. First of all, I was really great presentation by Dr. Shannon. It's really great to see young doctors like you doing so well, and it really inspires people like me to do better. My question, I mean, this is coincidentally, this is a very relevant talk to what we have been working in our hospital right now here in India. I right now I'm in a state which used to be a part of Madhya Pradesh. I'm in a state called Chhattisgarh, which is the state where Nandita ma'am right now lives. I'm in a city called Durg, and our hospital we have a small hospital which generally we have two specialties basically in our hospital. We have gynecology and pediatrics plus orthopedics. And what we tried out was so knee replacement surgeries, for example. We tried out a super fast timeline for knee replacement surgeries, wherein we used to send people home after 36 hours, and their rehabilitation and everything used to continue from home. So their average home stay was average stay in the hospital was decreased by a lot. And we use something called RACE service, which is the remote access consultation and evaluation services. And it is quite a capital intensive thing to work out the RACE services, especially for a small hospital like us, because India is in a very nascent stage when it comes to the electronic health records or something resembling an electronic health record being available on national level. So we had to develop, or we had to at least buy that system ourselves. One of the things that came out of that discussion actually that we have had success with these rehabilitating patients at their home and sending them home quite soon was that can we use these telehealth services to bring specialist care to a few villages around our city? And we were looking at these telepresence robots to essentially get people from villages not come to the city, but go to the primary health centers where we would place these robots, and they could sit there and the doctor could evaluate them from here. But there are a few things, because again we would have to invest in these electronic health records thing, and we would also have to invest in these robots, which at least from our perspective are quite expensive. It's like $3,800 for a telepresence health robot. So my question for you or anyone, especially Dr. Shannon, because he's worked with this sort of thing, is that do you think this sort of thing has a good return on investment? Because it does look good when I talk about it to people, but from a financial perspective, would our hospital be at an extreme loss? Or would we be just the first people adapting to a new technology? Because telehealth in India is quite a new thing. It started out recently, as ma'am has said right now in the previous comment. So yeah.
Shannon?
Thanks, Tapesh. It sounds like you're doing fantastic things there in India, and I think that your examples just are some of many that I'm sure people across this webinar tonight could share in terms of ways people have adapted. I think first thing, the concept of telehealth or telemedicine rehab is not new. There's quite a few programs globally that have been running tele-rehabilitation services, and that can be from your post-op conditions like you're discussing in regards to knee replacements, through to COPD or respiratory rehab or cardiopulmonary rehab, or even just in regards to post-op from any condition. So there's certainly a lot of evidence for that, particularly in rural and remote regions where we might not always have the suite of subspecialised allied health support in towns. And so I think you could leverage some of the international literature. There's quite a fair bit growing out of Australia. I know Canada and the US have utilised this as well, and parts of Europe in regards to telehealth rehab. In regards to business cases, obviously I'm not familiar with all of the funding levers that you would have there, but I think one of the big things as we move into new models of care is that, one, we need to understand what problem we're solving, but two, really understand it from an evaluation perspective and across a quadruple aim. And for those people that might not be familiar with that terminology, it's looking at patient and clinician experience as two prongs, patient outcomes as another one, and then looking at the organisational outcomes, which would also look at financial sustainability. One of the big challenge, I think, for all of us as doctors is that that last component is not always easy to quantify, because cost is not always a linear thing that you can show. If we do X, we drop money here so that it's effective for hospital X, because healthcare spans a whole range of cost areas, from travel to also, I suppose, opportunity cost and all of those type of things that economists are really good at hopefully measuring, but financial people within hospitals don't always see the net benefit. So I think the big thing is, if you're in a hospital system, is really being able to pick the brains of your executive around what is important, aligning with strategy that your organisation may have, and really leveraging somebody that understands the funding levers to be able to support these business cases, because some will be easier than others, and at the end of the day, there will be areas that we need to invest in. One of the things that I think everybody would appreciate is that we can't, I suppose, as healthcare systems become more and more expensive globally, we can't continue to just tack on more and more and more without necessarily removing some of the low value care that's provided across the system. And there is a lot of low value care, and that needs to be defined and addressed. And that's not always a direct correlation with new telehealth programs. That might be just a completely removed program that is not achieving the goals or patient care that it needs to provide. And certainly there's great evidence and I suppose growing interest across the health space around the concept of low value care, as well as unwarranted clinical variance or unwarranted variance in healthcare systems, which could also include unwarranted cost variance depending on clinicians or surgeries or interventions and that side of things. So probably not as helpful in terms of giving you exact examples in terms of return on investment for you there locally, but there's some things that need to be considered as you look at any new project.
Thanks, Shannon. I've just I've asked. Oh, sorry, Tapesh. We're on. Did you want to just
I just said thank you.
Quick comment, given our time. Go ahead.
No, I just said thank you for the comments to Dr. Shannon. That's it.
Excellent. Thank you. Has anyone got any final things that they think we missed out on that you'd like to bring up as a point? And then I'm going to ask Shannon just to maybe summarise a couple of things he thinks we should do, a couple of things we might need to be careful of or stop doing, and maybe just some reflections on what he's seen tonight. So anyone got any final questions or comments that they'd like to put forward before we go back to Shannon? Quick chance to say something. No, okay. I'll hand over to Shannon. Maybe you could just reflect on those things for us, Shannon.
Thanks, Bruce, and thank you everybody for joining us tonight. It's great to see so many different people from across the globe joining for a conversation. I think to Bruce's points around some things to do, I think that as we reflect on COVID is really be able to start thinking about what's worked well within your own context, and learn from the collective wisdom of clinicians in your jurisdictions, your facilities, even your individual practices around what have we learned out of COVID in regards to our ways of working that we need to continue to do or continue to improve on in the future. One thing with that I would say that for anyone thinking about any digitally enabled healthcare program, whether it's something from a mobile phone app through to video conferencing with patients, through to more sophisticated programs that utilize AI and advances in technology, is really understand what it is that you're trying to solve, what is the problem that you're trying to solve, what is the outcome.
Then I sit down on the sofa and I just do some social media and I check up with everything that's happened on my phone when I slept.
Sorry, I'll just repeat that. Everyone will be a moment.
Moments of our morning routine, and that is this. We always start the day, well, after breakfast, with cuddles and
okay. I'll just unmute you, Shannon. There we go.
I think I'm unmuted there. Yeah. So understanding what is the problem you're trying to solve, and make sure that you design a model of care that is not necessarily swayed by technology. So understand how you would like your workflows, what you would like to design before even bothering going. If you're requiring a tech provider, really understand what it is you need from them before even going to them, because I've seen quite a number of organizations and individuals go, oh, we've got a problem that we've ill-defined, or they thought that they've defined well, but perhaps they hadn't. And then they get into an environment where there's so many tech providers that they get confused, or they get sold a product that they don't actually need. And then it's the vendor or the commercial industry that ends up pushing the clinicians to try and create problems that suits the technical solution or the ICT solution that they've procured. So I think one thing, regardless of whether you're just even looking at a telehealth platform, is really understand what it is you need, learn from others, learn from the evidence that's growing in this space before getting to tech providers. I think the worst thing that any clinician can do is allow a vendor or a company say, hey, we've got this fancy toy or program here, it can do all of these things, and then you start plugging in problems or healthcare problems that suit the solution as opposed to the solution helping you fix your problems. And then I suppose the final thing that I'll say in terms of reviewing tonight is that, and certainly I've had quite a number of conversations with colleagues in Australia and globally around telehealth and telehealth programs, is that there is clearly a lot of interest in this space and a lot of components that an opportunity where we can continue to improve the care we provide for patients. And I think one of those things that we must learn in terms of what we should do moving forward is ensure that we bring patients or consumers into the fold in regards to how we design our programs for the future. I think everybody has heard the term or used the term around patient-centered care, and this links back to one of the very early conversations around that case that was shared with us by Richard around people accessing their care. I think accessing their data is that we need to provide patients with choice where it's appropriate to do so. Choice doesn't mean we offer them things that would be potentially dangerous to them or not in their benefit, but we do need to be able to provide patients with choice in terms of choice of access and that side of things. We also need to be able to provide clinicians the ability to much more easily communicate or collaborate with one another. And in rural environments where we can have the capacity to potentially be professionally isolated, telehealth can bridge some of those gaps and allow us to bring more people to the patient's bedside, whether that be in a hospital setting, in a primary care setting, or in the home. Some of those clinicians might be face-to-face, and certainly I must stress that we need to make sure that we can continue to invest and look at how do we address some of the workforce challenges globally in regards to recruitment and retention of doctors and skilled clinicians in rural and remote communities. But we also need to look at ways that we can think outside the square in terms of how do we recruit and retain these clinicians in areas, how do we lessen the burden of being a doctor or a nurse in a small community that may be professionally isolated, and how do we also provide wraparound support for patients that regardless of where they present, whether it's the most remote parts of the world to our urban centres, how do we bring together evidence-based care that has high-performing teams at the patient's bedside, whether that be face-to-face or virtually. And I think that's the really important thing for us moving forward, is really thinking about virtual care is just an enabler. It's another tool that we have in our pockets. We need to think of it as a tool and an ability to be able to address some of our challenges moving forward. Thanks, Bruce.
Thanks, Shannon. I think you make a really important there at the end about this is not an excuse for diminishing services. This is a chance to improve services and to assist those that are on the ground, both patients and doctors, to have so much better care. So look, thanks everyone for your discussion tonight. Shannon's given you his email, and it was in. I sent it out as in the copy to the registrants tonight. So feel free to continue this discussion amongst yourselves and also with Shannon. And next week, I'm very pleased to say Pratish Kumar is going to talk about climate change and the rural effects of climate change. I think it's been brought into focus with the international discussions this week. But it is particularly relevant to some of our rural communities, particularly our coastal and island communities. So next week we have that, and then we have a little bit of a break before the 9th of January when we get back to our young doctors again, and we'll be getting expressions of interest from people in being involved in organising this. But we're going to have one of our famous rural cafes on the 9th of January, talking about some of the joys of practice and practicing in rural areas. So please join us next week, and then have a well-deserved break over the Christmas New Year, and we look forward to getting back into it on the 9th of January. So thanks everyone for your participation tonight. Thanks, Shannon, for your expertise. Shannon didn't say, but he's actually had a Churchill Fellowship to study this for almost a year, I think, and that's why. And he's a rural kid, going back to a rural area in rural New South Wales. And I'm very glad to see that New South Wales snapped him up to help organise their service there, and also to use that wonderful expertise. So thanks for your expertise tonight as a team too. And we look forward to catching up with you next week. So see you all, and thanks for your contributions.